All right. Well, thank you for the opportunity to give this presentation. My name is David Kong. I'm a neurosurgeon here at the RWJBarnabas Health System, and I'm also associate professor, associate program director, and co-director of the Endovascular Neurosurgery program in the health system and Rutgers University. So I was asked to talk about treatment for acute ischemic strokes, and I have no financial disclosure. Obviously, this is something that we, as neurologists and neurosurgeons, we care a lot about acute ischemic stroke. The definition of ischemic stroke is that essentially you don't have enough blood going to the brain, and most of the time is related to a blood clot that blocked off one or more blood vessel that goes to the brain. Um, in terms of the scale of the problem, approximately 800,000 patients per year in the United States experience a new or recurrent stroke. And that translates to about, amazingly, every 40 seconds, someone in the US have a stroke, and every 4 minutes, someone die from a stroke. And it costs the United States $46 billion per year. And as a comparison, in the US, the COVID death last year, which is the peak of COVID pandemic, the death rate was 771,000 patients. And you can see in this graph that majority of the stroke that we talk about are ischemic strokes. So 88% are patients not getting enough blood to part of their brain. And the other smaller percentage involve hemorrhage in the brain. So when it comes to treatment, the only way to treat ischemic stroke acutely, in terms of acute treatment, is restoration of blood flow to the brain. I mean, that's really the only way. If the brain's not getting enough blood, then you need to get blood to the brain. And it has to be done as quickly as possible. For a long time, there was actually no treatment until 1995. A series of study came out that showed this very powerful blood clot dissolving medications called TPA was helpful for acute ischemic stroke, and it's been around for a long time. And it became standard of care for stroke when the patient present within 4.5 hours of the initiation of the symptoms. The drug is very useful. However, it's not magic. It doesn't reverse every single stroke, and roughly it's about 10% absolute benefit. And another way of looking at it is the number needed to treat, meaning how many patients we have to treat to get the maximal benefit. It's about 10 if you present up to 3 hours, and the number needed to treat is actually around 20 if you present later, between 3 and 4.5 hours. The benefit is highly time dependent, as you see from this curve. The longer you wait it out, the lower the odds of getting a benefit from the medication. As I said, this is a pretty serious medication, and it really thins out the blood. So the potential complication include hemorrhage in the brain or hemorrhage internally in other part of the body. And some people also can develop a kind of allergic type of reaction that's called angioedema, that they can swell up a lot. And because of all this serious complication, it actually took a long time for physicians to become more comfortable using the medication. But 95, that was a long time ago. So, where were we in 95? Sometimes it doesn't feel like that long, but it's actually in 95, O.J. Simpson was actually acquitted. That seems a long time ago. And Windows 95 looks like this. And if we have a younger audience, if you can believe it, in 95, it takes 9 more years before Facebook and Gmail to exist. So so another point I want to make is that up to 35% of ischemic stroke are considered large vessel occlusion, meaning here's a picture of the blood vessel in the brain. Large vessel obviously means that the large pipe that ultimately spread into smaller vessels. So large vessel occlusion, as you can imagine, are much more deadly. So here in this chart, you can see ICA meaning internal carotid, meaning down here. If you occlude that vessel, you have 84% chance of death or terrible outcome. And if you go out a little bit further, MCA means somewhere in here. Proximal MCA, about 60% chance death or terrible outcome. So unfortunately, these are older slides. TPA doesn't work very well when it comes to large vessel occlusion. It's almost like you send this little truck to try to dig out this large blood clot in the canal. So for example, in the ICA, only 4.4% chance the vessel will open back up if you give TPA. In basilar occlusion, which is only 4%. So with that, fortunately, over the year, after many iterations, in 2015, a series of study came out that demonstrated benefit of what we call mechanical thrombectomy. This is a surgical procedure in which the surgeon insert a device and catheters through, commonly through the femoral artery, and nowadays sometimes we go through the radial artery in the wrist, and we can thread the catheters and device all the way up into the brain, go inside, and using this stent, what we call stent retriever and suction device, we can remove blood clot straight out of the brain, blood vessel directly. Here's some example of the clot that we pull out. I'll show you a few case illustration. This is a 57-year-old man. He's a construction worker. So while at work, all of a sudden he can't talk, and his right side feel weak and he feel numb on the right side. His symptom onset was around lunchtime, and very thankfully, his coworker noticed that and did the right thing, which is send him to the hospital rather than tell him to just tough it out. So he arrived to our hospital emergency room around 2 o'clock. We noted that he probably is having a stroke, and we did some imaging study, which in this scan, the green area indicates the area of the brain that is not getting enough blood. And here, it's a little bit hard to interpret, but if you can imagine, there's like a stump here, that the vessel is occluded at this stump here. So since he presented within 3 hours, we gave TPA, and then we took him for mechanical thrombectomy very quickly. And here's what the intraoperative angiogram looks like. Here's a blood vessel. As it come out through the neck, it enter into the brain. And it's come out, you see it stopped here. There's a stump here. And this is looking at it from the side view. There's a stump here. And you see this part of the brain is not filled with blood vessel. So clearly, it's a proximal, or somewhat proximal occlusion. We consider that large vessel occlusion, and we were able to open it very quickly. And here's afterward. You see the vessel recannulized, and the brain is receiving a lot more blood. So in terms of the timeline, the patient symptoms onset was 12:30. He came to us at 2 o'clock. In 29 minutes, we initiated TPA. We got the scan, evaluated him, initiated the blood thinner medication. And he was on the operating table at 3:15. And for this case, took us 18 minutes to open the vessel, which is about average. But thankfully, on discharge, the patient was completely normal. Here's another illustration. He's a 66-year-old man. He has atrial fibrillation, which is a well-known risk for stroke. He's supposed to be on blood thinner, but he didn't take his medication for 8 months. On top of it, he has systolic heart failure, and he was, instead of taking his blood thinner, he was taking some cocaine. So he presented with very severe stroke, left-sided weakness, and disorientation. He initially showed up in the local hospital where they gave TPA and then transferred to us. He arrived about 4.5 hours after symptom onset. And he clearly has a large vessel occlusion, so he's a angiogram again. He's the stump, and you see this part of the brain is not getting blood. We're able to open the vessel. Again, you see now all these blood vessels are filling with contrast, which means blood can go through it, and the brain is much better perfused. This case from door to groin took 46 minutes to get him in the operating room, and from groin puncture to vessel opening took us 8 minutes. And again, very thankfully, on discharge, the patient was walking independently and he has minimal symptoms. This usually doesn't happen. I mean, if you don't open the vessel, I mean, you will have a massive stroke. So one more good case, a 43-year-old previously healthy man. I think this case illustrates that oftentimes we don't think 43-year-old guys can get a stroke, but they can. So keep that in mind. He arrived 3 hours after symptom onset, after he received TPA locally. And the CTA demonstrated terminal ICA occlusion. And if you remember from some of the previous slide, terminal ICA occlusion, the mortality rate is very, very high, especially on the left side. So here on the left was the initial imaging. You see the catheters here. When we inject the contrast, it can't stop here. It doesn't even go into the brain. We're able to open the vessel and everything opened back up. This case took 12 minutes to open up the vessels. And later on, we found out he actually has a hematologic variant that predisposes him to stroke. And he also has what we call a PFO. There's a hole in the heart that also predisposes him to a stroke. And instead of dying, 6 weeks later, when I saw him back, he has minimal speech difficulty and he returned to full-time work. This is one last case. And this is what I want to show what happened if we were not able to do the optimal treatment. This is a 57-year-old lady with hypertension and COPD. He arrived at our hospital 6 hours later. And this is the initial CT scan. As you can see on this side of the screen, where my cursor is, there's a large area that looks kind of darker gray, which to us indicate that those are irreversibly damaged brain. So unfortunately, she's not a candidate for TPA and she's not a candidate for mechanical thrombectomy. And unfortunately for this lady, as you can imagine, if you have a large piece of tissue that are damaged, they tend to swell, just like if we fall on our knee. It takes a couple of days later, then your knee might swell up. So her swelling was so significant that we actually have to take off half her skull to allow the swelling to come outward rather than push on the normal side of the brain. And she required feeding tube and tracheostomy. And obviously, the outcome is not as good as the previous cases. And after all of this, she still needs another surgery to put the bone back in her head. And she remain dependent in daily activities. So this chart is a little bit hard to interpret, but it indicates that the growth of the damage, irreversibly damaged brain is different in every single patient. So we don't know who can last 4 hours, who can last 2 hours, or who will have irreversible damage within, say, 1 hour. Therefore, we have to move fast for every single patient. These are some of the more modern CT technique for looking at for judging whose brain is salvageable and who's irreversibly damaged. And nowadays we have artificial intelligence software that can tell us, for example, in this illustration, the pink area is what's considered irreversibly damaged, and the green area is considered salvageable. So in this patient, there's still plenty of brain that's salvageable. So we will go for mechanical thrombectomy. The mechanical thrombectomy is really a revolutionary treatment. If you look at, in comparison to other treatment, this is, if you have a heart attack, you go for lysis with endovascular technique. In terms of preventing mortality, you have to, 1 out of 29 patients get benefit, as opposed to thrombectomy for the brain, it's 1 out of 4. This may be a little bit unfair comparison, but it illustrates how beneficial it is in the right patient for mechanical thrombectomy. This is another table that demonstrates other treatment that we swear by, for example, giving aspirin for stroke patient. The so-called number needed to treat is 83. So the higher the number, the weaker the benefit, okay? As opposed to mechanical thrombectomy, the number is 3 to 7. Other example, for example, if you have severe occlusion of your carotid artery in the neck, we sometimes would recommend surgery to remove the plaque, but the number needed to treat is actually fairly high, it's at 26. So this illustrates how strongly beneficial mechanical thrombectomy is as a treatment option. So the benefit of endovascular technique is there's no systemic anticoagulation effect, so you're not going to bleed in the body, and the rate of reopening the blood vessel is much higher. It's as high as 86% in one of the trial. The disadvantage is obviously you require a specialized team, require a specialized hospital, and it's resource intensive. And one other point that have to be made is that it's also very highly time dependent. This is one of the publication that in this chart, it illustrates that for 1 hour delay, you essentially eliminate 1 year of healthy, happy life. So even a 10-minute delay will cost the patient 2 months of healthy life. This is a little bit of a statistic manipulation to this kind of chart, but I think it illustrates very well how highly time dependent this is. And here at our health system, at RWJBarnabas health system, we pay a lot of attention to this, and we invest heavily on this. For example, one of the points we make is that even if the surgeon can see the images faster, it on average save about 20 minutes. So at least we don't have to log into the computer, go through a bunch of radiology gateway to see the images. By saving this about 30 minutes, will translate to 136 to 225 days of healthy life per patient, which is significant. And for 225 days is the damage of forcing someone to smoke close to 30,000 cigarettes per patient. Again, this is probably not the right way to do the statistic, but I think it illustrates how significant it is to move quickly. So other thing that we still investigating are what we call medium vessel occlusion. How small a vessel can we go out to retrieve the clot? other ways to go faster. For example, go directly to the angio suite or the operating room. We're investigating newer drug in other than TPA and newer device to be able to do the surgery safer and better. But in terms of optimal stroke care delivery, it's not just the surgery, it's not just the physician opening blood vessels. It really starts with the community. We need more extensive public education, such as seminars like this, to allow early recognition of stroke and proper use of the emergency system. In terms of the emergency service, it would be ideal to have new tools to identify who's actually having a stroke, who's not having a stroke. That's actually very difficult to achieve. And we have to develop pathway for the emergency service to transport the patient to the right hospital. And also, in terms of the hospital, we have to find a way to improve availability without over-diluting the case experience. It's probably not ideal for every hospital to be able to do this because it will dilute the system experience too much that you don't want every surgeon who have done only do 2 or 3 of these cases per year. You want experienced surgeon to do this, but you want it to be available to the community as well. So it's always a balance that we have to work on. And this is another chart demonstrating that the system of care for stroke really starts with the community, and they go to pre-hospital delivery, hospital care, and then post-hospital discharge and rehabilitation. And sometimes running systems like this is kind of like this guy, flying in the air, but you can't stop flying, but you have to go out and fix the engine. So it's a recurrent iterative improvement process. When it comes to secondary prevention means after you have a stroke, what can you do to avoid another stroke? It mainly, we focus on the vascular risk factor, which means typically hypertension, diabetes, smoking, and cholesterol. Those are easy to say, but very hard to achieve. We encourage healthy diet, regular exercise. Again, easy to say, hard to do. There are many newer drugs, antiplatelet and anticoagulation, that has been shown to be beneficial, and treatment of known stroke etiology, such as atrial fibrillation, carotid disease, or PFO. We're making development in terms of judging who need to be treated for those. How about effect of primary prevention? Meaning, if you never have a stroke but want to avoid having a stroke, that's primary prevention. I think also as a society, we'll make a lot of improvement. This is a picture probably in the 60s, 50s or 60s. Back in the days, after dinner, everyone smoked, everyone drank, heavy drinking, heavy serious dessert and pies, and everyone smoked. It's like no big deal. Nowadays, we don't see pictures like this. People tend not to smoke as much, which is a major advance in public health. And this stuff actually do make a huge difference. Here are a couple of studies that mainly European study demonstrating healthy lifestyle improve the stroke and vascular risk. In this case, 20,000 patients in Sweden had an 86% drop in having a heart attack. In 2 other studies demonstrating very significant decrease in stroke risk. But these are hard to do. When they say healthy lifestyle, what do they mean? They mean no smoking, BMI less than 25, and that is not a typical American. Typical American BMI is most definitely higher than 25. And everyone patient should have more than 30 minutes of daily moderate activity, and don't drink so much, and healthy diet. So this we know is easy to say. We advocate this for a long time, and we partner with primary physician to do this. And what we found is that it's easy to give medication. So when you look at post-stroke patients, most of them are on appropriate antiplatelet agent or anticoagulation. Most patients, if they require surgery to prevent another stroke, they will have the surgery. But very much smaller percentage will achieve the ideal blood pressure and blood sugar goal, because those involve really truly a lifestyle changes. Here's another graph from the American Health Association advocating the slogan is Life Simple 7, which to me is actually 3. So the 7 include blood pressure control, lipid, meaning cholesterol, weight control, healthy diet, reduce diabetes risk, regular physical activity, and no smoking. So when you narrow it down, what can you do about it? Well, how you go to decrease blood pressure really is by doing healthy diet, regular exercise, and no smoking. So if you only do 3, exercise, diet, and not smoking, you can partially achieve some of this, at least weight loss, blood pressure, diabetes, and cholesterol. So instead of 7, you actually have 3 things to do. So that's my brief presentation. I look forward to any discussion and comments.